Hello, everyone, and welcome. Thank you for joining us for today's presentation, Advanced Care Planning Education, Empowerment, and Advocacy, presented by Compassion and Choices and hosted by the American Society on Aging. We will begin shortly, but before we do, a few housekeeping notes. I would like to direct you to the left side of your screen where you will see five tabs labeled Speaker Bio, Important Information on Group Viewing, CE Application Here, FAQ/Troubleshoot, and Event Resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You will find information on how to obtain CE credits for this event under the CE Application Here tab, including links to the application and to the step-by-step CE guidance webpage. Please take the time to review the guide before submitting an application. You will be able to access the CE application a minimum of 2 hours after viewing the webinar once attendance is received and recorded, although it may take a little longer, so we appreciate your patience. Please be aware that your time is logged and you must view the entire hour-long webinar to be eligible for CE credit and access the application. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. Follow-up emails are sent by the end of the live event business day that will direct you on how to claim CEs and include links to today's slides and recordings. You have 60 days from the live event date to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get to those questions in the last few minutes of today's programming. And now I would like to welcome our presenter, Missy Moore. RN has a wealth of experience and knowledge in nursing that spans more than 37 years, including extensive experience in hospice, long-term care, nursing regulation, wound care, and networking. Moore plans to share her nursing experience with healthcare providers and mentors many nurses before she retires. Missy, we are so excited to have you here with us today.
Well, thank you so much for having me. I'm excited about being here. And, advanced care planning is a tough topic, but very, very important. Compassionate Choices improves care, expands options, and empowers everyone to chart their end of life journey. Our training objectives for today are to identify end of life issues that need to be addressed, discuss ways to start a conversation about advanced care directives, and to educate, empower, and prepare consumers and caregivers to be their own best advocates. So before I move forward in the questions and answers, if you would type in the questions and answers the answer to this question for me. Have you personally prepared an advanced care directive for yourself? Now, I'm not taking off any points for a test or anything like that. The reason why I'm asking is because as providers, as healthcare providers, we ask our patients, our clients, to complete them every day. We give them the paperwork for it. We try to explain it to them every day. But unless we've really taken a look at it, looked at all of the components ourselves, we actually haven't put ourselves in the shoes of the patient. So I just want us to think about that, whether or not if we have, what our experience has been like, and if we haven't, then maybe we can consider it. If for no other reason, number one, for ourselves, because advanced care directives are a gift to our families. It saves a lot of turmoil when our illness becomes overwhelming, and when it keeps them from having to make decisions they may not want to make, and it really tells them the things that we want. Our next slide, we have a video, a short video we're going to watch.
At Compassionate Choices, we have worked with different community groups and community leaders to start having these conversations before a time of crisis, so that we are sort of desensitizing ourselves to the subject of death and taking sort of the fear aspect away from it and the mystery around dying and really planning for it.
We plan all the time for everything. You know, we plan for birthdays, we plan for weddings, we plan just because. And I think that we need to plan for your end of life.
There are many, many psychological, very positive effects when it comes to planning. Because planning means what? That you have the mind and the will to be able to look into the future. Planning means to be able to look at your goals, where you have the ultimate decision, but you do have the opinions and the support of those around you.
Sometimes it gets hard, because you're bumping heads when you start hitting with people's belief systems.
I have noticed that with blacks that we have a tendency of not to want to talk about death or not even think about death in any way. And so I realize with my members, their knowledge of even making preparation from death is very low, but I tend to add it into my pastoring them. I always have. But as a people, I think we tend to not want to even think about death.
My cousins and relatives used to tell me all the time, man, don't go to the doctor, because when you go to the doctor, man, when they come back from the doctor, they usually die. But they don't understand that what happened was that because you didn't go to the doctor, all of this stuff was going on in your body, and now you at stage 4, and now the doctor says there's nothing I can do. So now I think what we have to do is prepare people and educate people.
Will you have all the answers if that person's in the emergency room or the person has passed? No. But at least you have some kind of roadmap before, if you have that conversation, So I think that in a perfect world, to make it run smoother, have the conversation now.
We have to continue to educate, push, and make people really understand and see. The best thing to do is to sit down and have a conversation.
It's a tough subject. But when you plan, things run smoother. It won't be perfect, but it'll be smoother.
We have created a lot of tools and resources that really can help foster that conversation and really break down those specific issues that you face at end of life.
So preparation for anything is good. You need to be prepared. So you get prepared by getting the information. That's the value of Compassionate Choices.
We found that just by even getting the information out there, that we can probably impact some of those disparities because people just aren't aware that they have access to some of these options.
So our video talks about how important completing your advanced care directives is, and having a group and having, whether or not it's your family, whether or not it's your church family, to support you to get these things completed. So before we get started, I wanted to set some ground rules for us to think about whether or not we're just in the community or whether or not we're professionals. We should avoid using medical and legal jargon when we're talking about advanced care directives. It should really be in plain language so that everybody understands what it is that we're trying to accomplish. We should address the patient's values, their preferred language, and their health literacy level. We should be speaking in terms that everyone understands. Also, if English is their second or third language, then perhaps we need to get an interpreter just so that it's more understandable in their native tongue. Find out how much everyone knows before offering new information because sometimes you know what someone may tell someone, you know what you have cancer and they may not hear it. So you may have to go in and start say, so tell me what you know about your illness. You may be starting literally from the beginning before you start to give information. Um, Show empathy by using compassionate, non-judgmental language. The I wish I could help you. I wish I understood more about what you were going through. Those types of things make um, a big difference in how someone is receiving what you're saying. Utilize culturally and language appropriate decision aids to enhance understanding. And by that I mean if you have someone that's from a different culture, make sure you understand how decisions are made. Are the decisions made by the head person that's a male, or is the decision made collectively by the family, or is the decision made by the head female in the family, or do they not tell the sick person that they're sick at all? All of these things are very important when you're trying to discuss what decisions are going to be made. So we're going to look at some definitions and we're going to take them all independently. We're going to talk about hospice, we're going to talk about palliative care, advanced directives, a living will, a DNR or do not resuscitate, a medical power of attorney, and voluntary stopping of eating and drinking. And I'm just going to give very simple definitions so that they can be utilized to help people understand what they are and perhaps what they aren't. Because when we talk about this topic, there is a lot of myths and misconceptions surrounding all of these definitions. So let's start with palliative care. Palliative care is specialized medical treatment for someone that's living with a serious illness. The care focuses on release of symptoms and stress. The goal is to improve the quality of care, and the care is provided by a team. The patient can pursue curative treatment. It can be provided in any stage of the illness, and it's patient centered and patient driven. So that means that the patient controls what it is that they want and what they don't want. Now let's talk about hospice. It's designed to provide supportive care to a patient and the family at the end of life. The patient has been given a life expectancy of 6 months or less. Care is provided by a team, an interprofessional approach. Now, it's 4 levels of hospice care, and this is important to know because a lot of times what's said is, well, I have to wait until the person does this, that, or the other before I can put them in hospice. It's 4 levels of hospice. The first is routine. If they feel like the person has 6 months or less to live, routine hospice means that it's the care is provided in their home, and their home can be wherever it is that they live. If they live in a nursing home, if they live in assisted living, if they live in an apartment, wherever that place may be is where they would receive the care. I have provided hospice care to a gentleman that lived in a shelter. So it's wherever they live. Also, continuous care. Continuous care is when a patient is unstable. That means that the hospice will have someone come to the patient's home and stay 24 hours until the patient is stable. They also have inpatient hospice. Where the patient is unstable, they will transfer the patient to inpatient care, and they will stay there until they're stable, and then they would go back home. And then, of course, it's respite. And respite is provided when the family needs a break, or sometimes the family gets sick, they need to go to the hospital. Hospice will provide around the clock care to support the family. So, those four levels of hospice care are very important for the patient, but also to support the family. The goal of to improve the quality of care of life the for the patient and family in hospice, and to support the dying process, to help them get their things in order, to get their so-called house in order, whatever it is they need, their arrangement to do their life review, all of those things. So, what do hospice and palliative care have in common? They're selected by choice of the patient and family. The goal is to improve the quality of life for the patient and the family. The care is provided by an interprofessional approach. So it's not just one group, one person that's managing it. It's a group of professionals that manage the care. The patient and the family are seen as one unit, and it's patient and family centered. Now, the other thing that I wanted to just touch on is some indicators for hospice, because that helps you to understand why um, patients may get may get a hospice referral. So it may be frequent trips to the emergency room, frequent infections, weight loss, um, changes in intake, frequent medication changes, um, falls, or just a steady decline. Those are some of the reasons that physicians or nurses may start to look at whether or not someone is declining and whether or not they may be hospice appropriate. So, one of the tools that Compassion and Choices has is the End of Life Decisions Guide. And the End of Life Decisions Guide is a book that has a, a, a wealth of information in it. And in this book, it's going to outline a lot of the things that we're going to be talking about today, including the components of an advanced care directive. So, and it's downloadable on the Compassion and Choices website. But it talks about hospice, it talks about palliative care, and it takes you step by step of what all of the components actually mean, so that you can talk to your family members, talk to your physician to make good decisions about the choices that you want for your life. So we're going to move on. So an advanced care planning is an ongoing conversation. So it isn't something that happens in one day. Now, I have a pie in the sky attitude. I think that advanced care planning should really start in primary care and should really start on admission when the patient starts to see their physician for the first time. That they should ask them, have you started to talk about who's going to be the decision maker if you become ill? That's important because, quite frankly, if we're talking about advanced care planning when somebody is in the hospital, then it's already too late. So, starting while they're a new patient is probably a good idea because it's less threatening. But it involves clarification of what an individual's wishes are, what their preferences are, and what their future goals are for their medical care. It's a comprehensive process. It's critically important to ensuring the patient receives the medical care that they want, in case they lose the capacity and can't make their own decisions anymore. And it bridges the gap between the medical care that the patient wants and the medical care that the patient receives. Um, positive that all of us have horror stories of patients that have told us things that they did or didn't want that they received, but because they didn't have an advanced, they didn't have some type of document in place that they were on ventilators, they had G tubes, and so on and so forth, and it was no recourse, or it was done because their family wanted it. I think we all can say that's something that we've seen. One of the great things about advanced care planning is that it's evidence based. The benefits are evidence based. Um, Healthcare professionals structured meaningful conversations with their patients. Guess what? Physicians now have a billing code that they can use when they discuss advanced care planning with their patients. Yes, I know they only have a few minutes for a visit, but if they're using a few more minutes to talk about advanced care planning, then they can bill for it. And I think that that's important that they're able to do that because this is important information that we're going to need later on down the line. It promotes patient centered care by focusing on the patient's personal preferences. It ensures the patient receives the care that's consistent with their preferences. It raises the likelihood that healthcare providers and families understand and comply with the patient's preferences. And we know for sure that sometimes that doesn't always work out, but we hope that it does. It increases the probability that patients with life-limiting illness can die with their preferred place, such as their home. When they've talked to patients who were who were expected to die, whether they were in hospice or not, the majority of the patients said they wanted to die at home. It allows healthcare professionals and caregivers to proactively arrange for the patients near the end of life to remain at home, in a nursing home, or in a hospice facility rather than going to the hospital. It reduces the decisional burden of the families. That's big. Having to make a decision, not necessarily knowing what the family member wants, or knowing what the family member wants, but having to deal with all of your other family members is tough. So it makes it very, very simple when everything is written. You can just go by what the document says. Enhances family satisfaction with the end of life care and understanding of what's expected during the loved one's dying process. Because if they've gone through the trouble of getting all of this filled out, then this family probably is more apt to engage in all of the other components that go along with what they're going to see in the dying process. It reduces moral distress among critical care nurses. Wow. Wow. I mean, we hear about it all the time, how often the critical care nurses are struggling with what they see um, in regards to patients that are receiving all of this life sustaining care, and it's frugal. It improves the bereavement experience of families by reducing stress, anxiety, and depression after the loved one's death services. It positively impacts quality of care and end of life care by preventing unwanted hospitalizations. I mean, those are all really important reasons why advanced directives are important for us to talk about. And it's a tough discussion. I'll share something. In 2017, I'm sorry, yeah, 2017, October of 2017, um, I was told that I was going to lose my son. And I had to tell my son that he didn't have long to live. but I wanted to talk to him about advanced care directives myself because I didn't want him to be afraid. I wanted him to hear it from somebody that could explain it to him and let him know that he was the decision maker. And I put it in a way so I was like, so son, um, we don't have a lot of time, but I want you to tell mom what the rest of your life is, how you want the rest of your life to be. And he didn't seem afraid at all. He talked about very freely what it was that he wanted, and whatever it was that he wanted, we did. I only had 24 days with my son from October the 1st to October the 24th. And from that, I learned that having this conversation is really very, very important. And it hurts. And you get a bad taste in your mouth having to have it. But what I realized is that it was one of the most important conversations um, that I've had and that I will probably ever have in my entire life. So let's talk about what an advance directive is. It's a written statement of a person's wishes regarding medical treatment. It's important that it's in place before the person becomes ill. You know, we should be talking about it while they're in primary care, while they're healthy, while they can think about it before they get sick and they're not stressed out. It should be discussed with all the family members. So they can tell the family, this is what I want. It should be changed it can be changed and revoked at any time. It's important to get copies to the healthcare providers. It's starting a conversation that says, and if they tell you they don't want to have the conversation, you can ask, tell me why this is so hard for you to talk about. Because they may have reasons for it. Or what would make this conversation easier? Sometimes it may be writing down what you want. Maybe it's because it's their child, or maybe it's because it's their parent, or maybe they need to talk to their sibling about it. And I want us to remember, sometimes we're not the right messenger. Sometimes it may need to be somebody else. It's not us personally. It's just that we're not the right messenger. We need to keep that in mind as well. Now let's talk about a do not resuscitate. Here's where I have a question for you. I want you to put this information in the box for me if you can, the questions and answers. I want you to put in the box how you would describe a DNR, but not use any technical terms, no technical terms whatsoever. I want you to describe it in a way that you would describe it to maybe a 7-year-old. This is going to be important because when we say, we all watch Grey's Anatomy and we all think we know what's going on. But I want us to remember that at a time when stress is very high, when emotions are very high, and we come in with this very technical word, do not resuscitate, and we're asking somebody to sign this form, do you want this person to be resuscitated? They're looking at you wide-eyed, and they have no idea what you mean, no matter what their education level is. So I want us to think about, if we had to think about it in simple terms, what would we say? How would we describe it? So I'm going to start off. So one of the things that I say is, if I have to talk to someone about a do not resuscitate, I would say, so the physician came in and he talked to you, and I guess the question that he asked was, would you like to allow a natural death, or would you like for them to do something else? Oh, almost every single person understands what I mean. Now, a lot of them do ask me, now, what do you mean by something else? And I say, well, would you like for them to try to bring you back? That's something simple to say, too. And then, I ask them the other questions that go along with it. So we understand that do not resuscitate is a medical order, making it clear an individual's request that no measures be taken to resuscitate them. But if you don't understand that resuscitation piece, because I want us to be more clear in what it is that we're asking people, because we're asking people to make life altering or life changing decisions. And I think that we should be clear about what it is that we're asking them. And the other question that we can ask is, what kind of medical care would you want if you were at the end of life? And you know what? Some people are clear about the things that they want. Now, they may not know the exact name for it, but we as professionals are able to fill it out. They may only can say it in plain language, but we can figure that part of it out. And that's where we're the translator. We're able to figure those things out. A living will. A living will is a document that expresses a person's end of life preference if they become unable to speak for themselves. That's the clincher. When we tell a patient what it is, this is something that's put in place so that if you're unable to make your own decisions, this person will speak for you. And then we also tell them it's only in place while you're alive, because, and we have to tell the person that signs that's named that's on the living will, because a lot of times they think it puts them in charge of everything when it doesn't. The most and the post form. The most and the post form, it stands for the medical or the physician's order for life-sustaining treatment. They're in different states, but this order is part of advanced healthcare planning and is prepared by a medical professional. It's printed in brightly colored paper, and it's usually put on a refrigerator, and it's used for emergencies. In some states, it's actually connected to the EMS system, the fire department, ambulance services, so that if 911 is called for a patient who has one, then they will know exactly what services can be provided to the patient and what can't. So this includes, it tells them what instructions should be and could be provided to the patient, to the house they go. So it could be CPR, whether it's a tube feeding or artificial hydration, which might be IV therapy, whether or not they should be transferred to the hospital, whether or not it's just comfort care or intermediate use of antibiotics and dialysis. The great thing about the most or the post form is that they can be utilized in every level of care in the state in which they're in. Now, the VSED is the voluntary stopping, eating, and drinking. This is a legal right for any individual who wishes to shorten their dying process by refusing nourishment orally or through a tube. I just want to be clear that this is different from a patient who may be actively dying who's unable to eat or drink. This is very different. VSED is a person who actively makes a decision that they just don't want to eat anymore. They have the right to do that, and they've started their journey not to eat or drink anymore. That's very different from a patient who may be actively dying, their body is shutting down, and they don't have the ability to eat or drink anymore. Two very, very different things. Okay. So we've gone through all of our definitions. I just wanted to be clear on what they all are. And okay, so now we're going to start to talk about how we start our conversation. So I met some wonderful ladies, Lisa and Lauren, and they developed the End of Life deck. And the End of Life deck is an unbelievable way to start conversations about end of life. If you're not comfortable with talking about it, then if you're a nurse or a social worker or a case manager or a navigator or just a family member, you can take that card every visit and just turn over a card and ask the person, one thing about their end of life journey or getting ready for their end of life journey, because it makes it easier. Is not as confrontational, and you're not as upset about it. So here's one of the questions. I can't read the question here. This is too small. But one of the questions that it asked was, who would you want to make your funeral arrangements? That's one of the questions that would be in the tools. Who is the person that you would want, or who would you want to make your funeral arrangements? Is that type of thing? Yeah, here it is. Who is it that you would want to make your funeral arrangements? I think that's an important question, because we usually want someone that understands what we want, and who's gonna do it the way that we want it done. Here's another great conversation starter. Growing up, my family dealt with death, A, by talking openly and sharing feelings, B, in a no-nonsense sort of way, or C, keeping it all bottled up and avoiding the discussion. This is a great question because it really helps you learn a lot about the patient, and it helps you understand how the patient grew up and how the patient deals with death. Now, for me, I like this question because growing up, I came from a family of undertakers. So everybody in my family talked about death all the time. So now it makes sense to me why it's very easy for me to talk about what may be going on in somebody's family. Here's another question that it asks. Have you chosen a final resting place? And it says, A, yes, I want to be with my family. It says B, just one place. Or it says C, in an urn beside you watching television. And it does have some funny things in it as well, because humor helps to take the edge off of it. But it's still a great tool. I have another tool. This tool is called the Lost Deck, and it has great questions as well. Here's one. What does the light at the end of the tunnel look like for you? Be as specific as you can. That's a great question for a dying patient. Just think about that for a minute. You have a patient, they're at the end of their life, and you ask them, what does the light look like? What does the light at the end of the tunnel look like for you? I think we'll be very surprised to hear what that's going to mean for a patient that's dying. That's something to consider. It really helps to engage us. It also helps engage the patient, to give the patient a better experience, to help them understand more about what their experience is, and to help them have a better experience. Here's one. What are the overwhelming emotions that you're dealing with? This is a great question for a caregiver. Because you know what? The caregivers are underwater all the time. So much so, they don't even know it. I'm sure that plenty of you have heard that, when they're caring for somebody that's dying, that a good amount of times, sometimes the caregiver goes first because they're doing so much. So when we talk to a caregiver and we ask them a question like this, then this helps us to start to think about what are some resources that we can put in place to support the caregiver so that they can get a break. Caretaking. What have you been neglecting in regards to your care and well-being? That's another great caregiver question. And it's also a great patient question, because sometimes they're so focused on their disease that they're not taking care of the other parts of themselves, like their family or their church life or their spirituality, because they're just so focused on their disease. These are all great ways to engage our patients and to connect with them. Here's a reflection card. This reflection card, here's one of the questions it asks. What is a memory that will forever make you laugh out loud? When I saw this card, I said, this is my favorite card ever, because I know that if I went to see a patient and I pulled this, this would be a card that I would pull out, and I know that I would ask them that, and then I know that if I went to their funeral and they asked me to say something, I would tell that story, because it would be something that would help me to remember the patient, something that I would be able to share with them, because they're sharing their journey with me. All of the other things that we've talked about, what hospice is and who they want to be in charge of them, and whether or not they want a DNR, and also what made them the happiest and what made them laugh the hardest. All of that is part of their journey too. There's some apps I want us to consider. The apps are Granted. If you get a chance, you can go on your cell phone. And Granted is an app that that helps navigate you through loss. It's a mobile app. It's for individuals, families, and caretakers. Um, it lets you know what to do before, during, and after losing your loved one, and it guides you through everything from planning the funeral, closing out financial accounts, filling out estate taxes, and helps users prioritize self-care as well. Vital Talk. Vital Talk is one of the best apps ever. If you are a healthcare professional, Vital Apps is going to be great for you. You can download it on your phone. It's a free app. It was put together by healthcare professionals, and it has every single thing that you would need to know in regards to having a conversation about end of life, whether or not it has to do with culture, communication skills, delivering bad news, food, serious illness, how to have family conferences, goals of care, all of those things, and even daily tips. So Vital Talk app is a wonderful app to support patients, caregivers, professionals in having end-of-life conversations. So in regards to advanced care planning, when we're talking about the document itself, it should be reviewed, the 5 Ds. So it should be every decade, so every 10 years. When it's a death, whenever you experience a death of a loved one, when it's a divorce, when you experience a divorce or other major family change, a diagnosis, when you have a newly diagnosed with a serious health condition, or when it's a significant decline or deterioration. So all of those are 5 really good reasons why you should consider making a change to your advanced care plan. When we the one thing that I love about Compassion and Choices is that we have an end-of-life information center and a consultation program, because we don't want people to have to try to do this on their own. It's a scary situation. You know what? You have the conversation, and then you have to try to fill out the paperwork on your own, and it's still scary, and you're still trying to make decisions. But if you go to our website, compassionandchoices.org, end of life planning, we have consultants that can help do further explaining for you, and also give you more resources in your state if you need additional assistance. We don't want you to feel like you're alone when you have to fill out this very, very important information. The other thing is that once you get it started, then once it's completed, then the only thing that you'll have to do is update it. Here's some other things that we have that are important. We've already talked about your end of life decision guide. We have the diagnosis decoder, which is a great tool. It's on the Compassionate Choices website. If you go on the website and hit the diagnosis decoder link, you put in the diagnosis, and it will tell you all of the information about a diagnosis, what it is that you can expect, and what exactly it means. Giving the consumer, the patients, information in plain language so that they can make decisions. Because sometimes as much as we think that we're doing the right thing or saying the right thing, a good amount of the population that we serve still walk away not really understanding all of the things that we're telling them. So this is a good way for them to go and do their own research to get a better understanding for themselves of what their experience is going to be. We also have dementia values and priority tools. They can go there if they have a diagnosis of dementia to take a look at the tools, even especially for advanced care planning, because the tools may be a little bit different. If you're early in your diagnosis of dementia, then you may want to start to do the tools so that when you can't make your decisions anymore, all of these things are started to put in place. And of course, we do have the COVID-19 toolkit. You know, COVID is gone, but not that much. So those things are still available if we need it. We have some frequently asked questions that are on our website as well. And, you know, one of the great things is that, you know, you can take the end of life decisions guide and you can take your cell phone and read the end of life decisions guide and videotape it and give it to your providers, and it's a legal document. It's legal. You can send it out to all of your family. You can video a video on your device, and it is appropriate. So I just want you to keep that in mind, because some people aren't able to sign or some people don't want to sign, but it's something that everyone would be able to see. So that's something to keep in mind. These are also some of the tools that we've already talked about. So to summarize, you know, talking about advanced care planning is a difficult conversation, and it's an important conversation, but it requires time and patience and compassion and empathy and skill. And if we just take a few more minutes and try to get a better understanding of what the patients understand, then perhaps we may be able to get more of our clients, of our patients, of the community to fill out their forms without being afraid of filling it out. So I think we have a few minutes left, and I am more than willing to take any questions at this time.
Thank you so much, Missy, for that presentation and for that message. I wholeheartedly agree. From my personal experience, I was the one that didn't want to have that conversation. It was very difficult for me. And my father wanted to have that conversation, and I told him, okay, when I get back from my trip, and unfortunately, he passed away suddenly before I came back. So don't put it off. even if it's difficult for you, definitely it's important to have this conversation. And so, in the last few minutes, let's get to some of these questions. One question is, if you don't have any family or friends, if you're a solo ager, um, how can you utilize advance directives, or what do you do if you don't have an executor?
If you don't have an executor, it's a few. If you don't have any family and friends, um, you can always go to the court and have them appoint someone for you. Or if you have perhaps a church family, someone from your church, or I would say someone from your church, someone that you know, either that or it would have to be someone that's court appointed because that's what would happen. So if you ended up in a hospital and it was nobody to make decisions for you, then someone would be court appointed. So you either would have to find someone yourself or you would have to get someone that's court appointed.
Okay, thank you.
Hmm.
And there was another question that it says, I I see often people opt for their family members to be full code when they may not understand the trauma that is chest compressions. What is a good way to inform a family on how rough a full code can be? Kind of following along the lines of let's try to put this in terms that people understand.
Hmm. Without scaring them, just ask them, are you have you been made aware of what cardiopulmonary resuscitation looks like? And are you aware of, uh, are you aware of the results of it? That way you can direct them to find out their own outcomes. Because if you tell them, then it may seem as though you're trying to direct them one way or the other. But if you ask them, have they done the research for it, then that makes them to go do the research for themselves. I think it's important that you and I've done that. Well, I think I want them to be a full code. Okay. In the meantime, I think that it's important that you research the outcomes from CPR on somebody that's this age, and then let's come back and talk about it. You know, because I think that it's important that we do that. You have someone, and you need to bring it up to them so that they in a way that they understand. Perhaps I want you to think about somebody that's 85 years old that has cancer, um, the chances of resuscitation for that person. I think perhaps maybe you should research that and then come back and talk about your decision. We're going to say we'll put your decision now, but I think that's something you should think about and come back to us. Let them think about it and come back to it. Let them do their research and come back to it because a good amount of the time they don't know what it entails. But if you
I'm
if
not.
you if you scare them, then they leave angry.
Yeah, that's a good point.
Mhm.
We have another question.
Mhm.
Is VSAT acknowledged in all states?
Uh, it's my understanding that VSID it can is acceptable in all 50 states.
Okay. And kind of in that same vein, if you have an advanced care plan created as a power of attorney or just an advanced care plan in another country, in Canada or anywhere outside of the U.S., is it still applicable in the U.S.?
That's a good question. Um, what I'll say is that I'm not sure of the answer of that question.
Okay, well, that's something for us to look into because that's a really good question. So
That is
um,
a really good question.
it's something
I
that you
would
don't think about often.
all I would say is I would hate to see the legalities of whoever didn't honor it.
mm,
If
yeah,
I
so
come in with it, if I come in with an advanced directive, wherever it came from, unless it was something that I couldn't read, it was in a different language. You know, I would hate to see what would happen if I didn't honor it.
And can a
That's a
responsible party who is not a healthcare proxy fill out an advance directive on behalf of someone else? So if there's no legal document, but it's just a caregiver, for example, are they able to fill it out for someone?
So they're the decision maker for it. Is this person in a long-term care facility?
It seems like it, based on the way that the question was asked.
Yeah, if the person is in a long-term care facility, I would say yes. If the person is independent, I would probably say no. Because in a long-term care facility, it runs a little bit different than if you're out on your own.
Okay, well, thank you so much for that information. We have another question.
Hmm.
Um, what does changes in intake mean?
Changes in intake. So if you have someone that's not eating or someone that's not drinking, that's the change in the intake. You know, if they're eating well and drinking well, that's one thing. But if they're not eating and drinking, that's a change in intake.
Okay. And then we also have a lot of questions regarding the decks, the end of life decks that you shared earlier.
Yes,
How can someone get those?
yes,
Those are great.
absolutely. Yeah. So the end of life. So listen, if you're on LinkedIn, go to the creator's name is Lisa Paul, Pahl. She's on LinkedIn, so be sure to go on there and tell her I said hey. But you can go to the .com because they have the death deck. That's a bigger deck, and then they also have the end of life deck, and you can purchase them there. The end of life deck, and you can get that, you can get it on the site. It's called the end of life, thedeathdeck.com. But they also sell them on Amazon.
Okay, well, I think that a lot of people were interested in it, so definitely going to see some traffic there. And
Good.
also, just as a reminder, you can go to compassionandchoices.org so that you're able to access those tools that were shared, as well as download the guide as well. So that's compassionandchoices.org, and that's deathdeck.com. It's
Death deck.
such a great name for a website, huh?
Yeah. Well, they do hospice and end of life, so it makes sense.
Yeah, it does make sense, and it's something that I'm not gonna forget. Like I'll remember that website. But thank you so much for sharing that. Thank you all for your questions. It really has been such a pleasure having you here today, and we want to thank Compassion and Choices for bringing this webinar to our audience. As a reminder, you will be able to access the CE application a minimum of 2 hours after viewing the webinar, although it may take up to 24 hours. So if you see a message that you have not attended when you did, it's because the attendance data still needs more time to sync. So please try back the next day. If not, feel free to send an email and we'll look into it for you. If you registered before the live webinar date, you will also receive a follow-up email by the end of the business day that will direct you on how to claim CEs and include links to today's slides and recording. If you have any questions about the webinar, please feel free to email ASA at info@asaging.org. You can also go to our website to see upcoming webinars, including the role of doulas at End of Life, presented by Compassion and Choices, scheduled for July 25th. And you can register for that at www.asaging.org. If you would like to share today's presentation with anyone, the CEs are available for a full 60 days. So thank you again, Missy. Thank you to Compassion and Choices, and we hope you will all join us again soon.